Fletcher's Solicitors are proud to sponsor the Mama Academy podcast series. We are one of the UK's leading birth injury specialists, trusted by families with the most complex legal cases. We champion better maternity care through every family's story. Fletcher's Solicitors, for every birth, for every baby, for every family. For more information about how we can help, visit www.fletchersolicitors.co.uk.
Hello and welcome to the Mama Podcast. This is the first episode in a brand new 10-part series created specifically for healthcare professionals working in maternity and neonatal care. Across the series, we'll be talking with leaders and changemakers from across the system, exploring what's needed to improve safety, equity, culture and outcomes, not through blame, but through learning, evidence and practical solutions that can be taken back into everyday practice. Today, we're starting with leadership and governance and what it really takes to make meaningful change. Our CEO, Heidi Eldridge, is joined by Dalvir Kandola, Consultant Midwife and Lead for Inclusivity and Nursing Times Midwife of the Year 2025. Let's get into episode 1 of our healthcare professional series.
Well, welcome to the Mama Podcast. I am Heidi Eldridge, your host for today, and I'm the founder and CEO of Mama Academy. And I'm here with Dalvir, who has just won the Nursing Times Midwife of the Year award for 2025. So congratulations, Dalvir. That's absolutely fabulous news. Would you like to start by telling our listeners all about you and your leadership journey? Because obviously we're here today to talk all about leadership in midwifery and how to make change.
Yeah, absolutely. Thanks, first of all, Heidi, for inviting me to attend to do this podcast on this topic. So I hope I can do it justice. So I'm Dalvir and I've been a midwife for 16 years this year and currently working as a consultant midwife lead for Inclusivity. And I've been in this role for 2 years. The role didn't exist before I came into it, so I think that would give some good insight in terms of leadership, because starting this role from scratch, which is huge, and kind of paving the way as to what we needed to achieve in this role has been really interesting. And then prior to this role, I worked, I'm going backwards a little bit in my journey, but prior to this role, I worked in education. So educating and supporting undergraduate student midwives, and I worked at 2 different universities doing that, as well as universities outside of where I work, supporting their processes, and that included abroad as well, which was really interesting. And then prior to that, I worked as a clinical midwife rotationally. I did that for 10 years and working in all areas of maternity. And on the side, I've had a few little things on the side as well. So I've also been a NMC Fitness to Practice panel member as well in my journey, amongst other things.
Wow, okay. So you've got a lot of strings to your bow then, a lot of experience. So tell us about the role that you're doing at the moment, because I know you've managed to make lots of different changes. So tell us about those changes that you've been able to make and how you've actually gone about it.
Yeah, so I think, first of all, well, in terms of what a consultant midwife means, there's 4 pillars to our post, and leadership is one of them. We've also got pillars on governance, research, education, and clinical expertise. And unlike other potential roles that you might consider to be leaders in maternity, consultant midwifery allows you to go really, really deep into leadership and your leadership style. So I think for lots of midwives, they might not feel that they have, or they are in a leadership position or have leadership abilities to make those changes in the work that they're doing. But what I'm here to say is you absolutely do. Doesn't matter if you're newly qualified or a labour ward coordinator or a matron, whatever levels that you work towards, we all have different levels of influences, and we are all leaders. Midwifery as a profession is being a leader. But what's different about being a consultant midwife to perhaps being a leader in a different role, such as a labour ward coordinator or head of midwifery or a matron, is that although there is some firefighting involved and some quick actions needed, as a consultant midwife, you can really go deep. It's not just surface level. You can really go deep into some of the issues, some of the changes that you need to implement, and therefore it allows you to kind of work towards a bit more of transformational leadership, and rather kind of doing that, perhaps that didactic way or autocratic way of potentially making change, which in some roles and in some leadership positions you may have to do, because that's the best way to achieve what you need to achieve in those roles. Whereas a consultant midwife, you really can go much deeper into that change.
Okay, and what changes have you been able to make over the last couple of years?
It's really difficult, because for me, I find it really difficult to say I've made a change in X, Y, and Z, because there's always so much to do. And I think that some of the things I feel that, well, a lot of the things that I've supported implemented are not quite finished yet, and there's always room for improvement. But some of the things that I've been working on is our trust, for example, have just been awarded gold for Pride in Practice. It's a gold award for healthcare excellence in LGBTQ healthcare, which is there to say that we have made a substantial improvement and paved the way for healthcare equity for the LGBTQ plus community within our perinatal services. So that was a massive achievement. But of course, in terms of the changes, those changes have to be sustained. So you get, it's great to have had that accolade and that award, but we've got to keep going with it. And nothing can stand still in midwifery or in this job. So you've got to keep on kind of making those changes and improvements. We've also kind of supported our staff with understanding the importance of health literacy, ensuring that our patient-facing information is at a reading age that is applicable and appropriate and matches the age of reading for the population that we serve. Traditionally, and still, a lot of patient-facing information is quite complex, quite difficult to understand, and has a really high reading age. In Leicester, we have an average reading age of 7 years old. Nationally, it sits around about 9 years old. So trying to support with some of that information, and once you've got it right with the health literacy, it will really help with things like translating resources. Because if you're translating something that's really complex, it's using medical terms, it can be really difficult to translate like for like. So supporting with health literacy. Recently, our trust has been awarded bronze status for anti-racism. So that was working with the Capital Midwives, so the first trust outside of London to achieve bronze status for anti-racism. So that's 12 months of working across nine different initiatives to support our organisation to really review our processes and look at what we can do to level up the playing field. What is it that's causing inequity, and how can we overcome that? So that's provided us a really good foundation now of what we need to do going forward. So there's lots of different steps that need to come on for that, and that's long term. Racism has been embedded within healthcare for a long time, so it's not going to be changed overnight. And it's taken 12 months to review our processes to go, this is what we need to do about it. So it's going to take a good few years of work now to implement that. So they're just some examples.
Just some.
So
They're huge achievements. Like, you must feel so proud. I mean, I completely understand what it's like to look ahead all the time and think, oh, but I've still got to do that, and I've still got to do that, and I've got a long way to go. But when you look back, they're massive achievements. And I would love to inspire our listeners today about how do you make that first step, because obviously you've had to get everyone on board to want to sign up to the anti-racism program, to want to sign up to the Pride program. So how do you get everybody on board to start the initial process in the first place?
I feel that I'm in a really fortunate position because the work that I'm doing is really well supported by the leaders above me, and by the trust, and by our senior leadership team. So that does make it easier, because I don't feel like I'm having to convince people that this is the right thing to do. That's already there. I have been in positions before where I've had to make change where perhaps people haven't supported things, and that's not to say that everybody has been supportive of some of the changes that have been made. I know I've given some good examples there, but there have been lots of other examples. It sounds easy when you're sharing about achievements. Oh, we've done this, we've done that, I've managed to implement this, etc. But in reality, there's a lot of work that goes into that to support the output and the impact that that has. And no matter what you do, even if it's the right thing to do because you feel it's the right thing to do, or if the evidence is telling you the right thing to do, there will always be resistance that comes with change. And if you don't acknowledge that or are aware of that, I think that is going to cause some difficulties in you implementing anything that you want. I think you've got to be aware of that. And it might not work for everybody, but one of the things that can work, that has worked in some of the other changes that I've made within the trust, is to get people who are going to be initiating the change kind of ground level and in their everyday practice, to see how they think that things can work for them. So for example, I'm in a strategic position at the moment, and I'm very aware of that. And so my day-to-day kind of practice as a midwife is very different to when I was working on the shop floor and working 100% clinically in the clinical areas, in the community, on the labour ward, in the ward areas. And so it's really important to get people who are in those clinical roles, if you're implementing something that's going to affect them on a day-to-day basis, to get them involved in part of that decision making for the change that you're implementing. Because I come with a different kind of hat and a different way of looking at things. Somebody else will come out with a different way of looking at things. So between you can see some of the benefits of what you both bring in, but also some of the challenges and trying to overcome some of those. It's not good if somebody's making a change for somebody else who's got to implement it and they don't get a say in how that's going to actually happen and actually come to fruition. Does that make sense?
Yeah,
you want to involve them right from the start, don't you?
Yeah, that makes complete sense. It helps to get everybody sort of on board, because then that's, if you get those decisions made and you get a tick in the box, then you've got to work on implementation. So you need their support to be able to actually implement the idea as well. So tell me a bit about implementation as well, and your top tips, because say you've got a new policy or a change that you want to make in practice, how do you make sure that that's always sustained and that's being carried out?
Yeah, it's really challenging. And if we want it, this is kind of embedded in behavioural science, but if you're wanting to change somebody's behaviour and the way that they do things, so a lot of the things that we do are out of habit sometimes, and so trying to change that can be quite difficult. And a lot of people or what has traditionally happened is just to rely on education. Well, let's tell people this is what we need to do and educate people why they need to do it. That is very important, don't get me wrong, because people have to absolutely understand why you're implementing a change, the rationale for it, because without that you don't quite understand why that's happening, and then you're not going to commit to it. So, but people have also got to have the capability to do what you're telling them to do, the opportunity to do that, and also the motivation. I think only with those three things could you then actually really change somebody's behaviour. And some of those are more challenging than others. But yes, people need to feel supported to make, say, a policy change or a guideline change, as you said. the opportunity to be able to do that. So if it does require some resources or some education or a different way of doing things, what is it that they need in their kind of toolbox of their everyday practice to be able to have that, to do that? But then also that motivation. So perhaps that comes with understanding, okay, I'm going to feel motivated to do this because I know it's going to make a difference to the women and the birthing people or to my patients. Yeah, so that a combination of all of those things will kind of help with that, help with that sustained element of change. But I think it's really important as well to give people updates on how that change is working and is it working, and to get some feedback. So you might want to pilot something and then think, okay, not sure how that's, let's have you try something and then you can get some feedback as to how that's working. Do we need some tweaks? So you might have thought about some ways of implementing a change, but it might not have really worked out like that when you put it into practice. So what could we change about that? So some of a couple examples really with that is I've been doing some work with our community midwives in supporting with implementing free vitamin D. So that was one of the big initiatives that we've supported where I work, is to encourage vitamin D uptake throughout the whole of pregnancy. And our midwives, or many midwives and pregnant people, are aware of why people need to take folic acid. That has been ingrained and people know about it. But vitamin D, not so much. If we were to ask people about vitamin D, we found that people know it's about healthy bones, to prevent rickets. You get it from the sunshine. But it's also evidence-based to prevent, if you take vitamin D throughout your pregnancy, reduces your chances of getting diabetes, reduces your chances of getting a smaller baby, reduces your chances of preterm birth. So really wanted to start to introduce that, because the Embrace report and other national inquiries are telling us that certain pockets of pregnant women, particularly by ethnicity and areas of deprivation, weren't taking vitamin D throughout their pregnancy. So it was a cause for health inequalities. And so introducing free vitamin D to everybody and anybody that needed was a key initiative. But it came to our community midwives to be able to give that out. So whilst I can support the initiative, look at potentially where we can source money to be able to do that, how are we going to audit that, who is it going to go to, amend our guideline, provide some education for the staff. The people doing the doing is our community midwives. And the same goes that I've also supported with a project on similar thing, but with the ferrous sulfate iron tablets. So the first dose can be given by the midwife rather than the GP or the pharmacist. Subsequent doses absolutely have to go through pharmacy, GP, but just to bridge that gap, so we're not delaying. You know, we've got the pregnant person in front of us, so you can give them the iron there and then. They've got something to start off whilst they're waiting the couple of days that you've got to wait for your prescription to come through. But that process of getting that to the community midwives and how they're going to dispense that and document that, you know, that all had to come from our community midwives and getting their thoughts and saying, this is what we'd like to do, this is why, how do you envisage seeing that into practice? So got their thoughts, got their ideas, looked at how we can implement that, and then couple of months later, looked at our compliance rate. Is it what we expected? You know, what did we foresee? Could we do anything better? Get some feedback from midwives. What's working? What's not working? You know, the community midwives had come up with an idea of some stickers on the notes to help prompt them to ask about these vitamin tablets, for example, and the iron. But then they weren't in the right place to prompt, and so we changed the colour of them and placed them on the front of the notes instead of you know, wherever they were before. So you know, those small changes can really make a difference with kind of sustaining that impact and that change.
That's all about measuring outcomes and how you it and how you're going to tweak things to make sure it's more practical, I suppose, in the right setting. And everyone learns in different ways, don't they? Some people are quite visual, some people prefer phone calls, some people prefer to be told in a staff weekly meeting. So I guess it's just working out what's best for everyone, how people learn. and not to think of it as a tick box exercise. I remember you saying to me before, like, you can send an email or you can stick a poster up, but how effective is that going to be? How are you going to make sure that people have read the email or seen the poster? You know, remember to do that. So that's all sort of things to take into consideration, isn't it?
Well, yeah, you know, absolutely. We all get so many emails, don't we? And there is change being implemented, or a new thing that we're supposed to be doing in our practice every day. And whilst emails and posters and things like that do have a part to play in some changes, we do have to, that is quite surface level, and that's kind of where I was going with that transformational leadership, is what can we do above and beyond that, that makes that sustained change, because you can become less observant of posters. If you're always working in a clinical area, you're not necessarily going to notice those things go up, and with the amount of emails that are coming through, so how else can we support with that? So an example being, the Race Health Observatory have released some guidance and some visuals about how we can support with detecting jaundice in black and brown babies, and they have got infographics on those posters. So absolutely, we have made use of those, and you know, they're in our nurseries now, and our community midwives have them to hand, so they can use them to explain about some of the signs and symptoms of jaundice in black and brown babies, and use that as a tool and a visual and a prompt with the parents. But also we need to have a look at whether our guidelines are matching that evidence, so a guideline change. What about our mandatory education that we're providing yearly to our staff on the jaundice topic? And then on top of that, you know, what are actually our staff doing? Because, you know, for a long time we have reviewed babies in the same way, and now we're encouraging midwives, nursery nurses, doctors to do skin blanch test and observing the soles of the feet, which isn't necessarily something new in an examination, but something that can tell you a little bit more about whether a baby's got jaundice or not, particularly in black and brown babies. So having that in your kind of toolbox in any baby that you examine, that you do that as part of your examination. So part of what I've been doing is going out and speaking to the staff, our nursery nurses who do these examinations, for example, on a day-to-day basis, and say, do you do this? Have you seen this poster? So yes, they've seen the poster. Have they read it is a different matter. Now I'm going there and kind of having a conversation about what it's telling us and what we should be doing, and then that gives them some, and have a detailed conversation, and then that message kind of sinks in a little bit more, then that you might pay a bit more attention to that poster that's come up, or that email that's landed in your inbox, or something like that, because you do need to have the understanding of where this information is coming from for you to be able to confidently put it into practice. So for sure, yes, emails can only go so far with some changes. Yeah.
Exactly, that's a really good example. I'm just thinking of jaundice. We've updated our wellbeing audits now as well. So there's a QR code that goes onto a web page, so parents can find out the signs and symptoms as well on there. So I'm really pleased you mentioned that, because it's such an important factor. So talking about leading change, why is it so important in midwifery in particular?
If we don't lead change, if we don't initiate and support change, we're only ever going to keep getting the outcomes that we have previously got. And I think that's where my role is quite challenging, because these inequities in maternity care have existed for a long time. And when I started my role 2 years ago, lots of people were talking about these inequities. But what were we and they actually doing about it? And really only very recently, kind of over the last 6 months, maybe a little bit longer, 6 to 8 months, have guidance started to come out about some of the kind of, you know, top tips about what you can do, and the evidence base behind some of the changes of what you can do. And I think, you know, okay, so we all need guidance in terms of how to make those changes, and what works, and acknowledging that our maternity services and the healthcare has been designed to meet population needs of people who do speak English, who are white British, who aren't neurodiverse and are neurotypical, who don't have any disabilities. And our population isn't that at all, and it is changing. And so it's really important that we do support change like that in our services, because otherwise we're going to continue to widen that inequality gap. So it's really, really important, and you can make that change no matter what grade you are.
So there's a really interesting question as well, because I know that you sort of left for a while and then came back because you weren't sure about your progression. Tell us about that.
Yeah, so when I started as a newly qualified midwife, so we start as a band 5 as a newly qualified midwife, and then after a year, you pick with some certain competencies that you have to achieve, you then get to a band 6. And whilst I was working as a band 6 midwife, I completed a master's in health studies. So I did that part-time alongside my full-time role. Completed the master's, and at that point was the only person in the trust working as a midwife with a master's. And I thought, why did I do that?
What a huge achievement, Dalvir. I mean, that's incredible.
It was, but that was the thing. I did it, and I felt like it was a huge achievement. But what was I going to do with it? And at that point, I mean, we are talking a while ago, and things have definitely changed kind of over the last five years for sure. But when I started as a midwife, your progression, what you thought progression would be a band 5, then you become a band 6, and then you become a band 7 labour ward coordinator. I never really kind of go beyond that. But then the next career progression would be matron. And so that's what I thought that you would have to do. And I think a lot of people at that time would have thought that that's what you had, that's what your career progression would be as a midwife. So I did my band 5, I went into a band 6, got my master's, and was a very experienced band 6, and was kind of filling the shoes for band 7 at some point, but wasn't a band 7 by banding, and never wanted to be either. And I think at that point I realised, for me, I don't think my strengths and my skill set lay with being a band 7 labour ward coordinator or a band 7 ward manager. And so I thought, well, what am I going to do then with my career and progressing my career? And that's when the opportunity came up to work at the university, and you did have to have a master's to be able to transition to work in education. So that's what I did. So I stepped away from clinical practice. Well, not completely. I worked on the bank for a couple of years whilst I was in education, and moved into education, and then worked up kind of there within education. So starting from assistant lecturer to a lecturer, and all the way to assistant professor whilst I was in, and lots of kind of CPD that had to go alongside that. And then whilst I was at the university, the job came up of being a consultant midwife, and then I stepped back into the NHS. So I think you're absolutely right, Heidi. For me, I didn't see this is what my career would be 16 years later. I thought that that's all you could do was be a 5 by a 6. I went from a 5 to a 6, moved into the academic world, progressed through the academic world, which is completely different. I said the word grade earlier. It's because that's what they say in the university, grading. In the NHS, it's banding. Worked through my grading there, but went back in the NHS as a grade 8B, as a band 8B. When I left, I was a 6. So my progression, it doesn't have to come all within that same space that you're working, because I progressed elsewhere and then brought in those skills here as a consultant midwife now. So that was really important, because I don't know if that was that it definitely wasn't around when I started midwifery that was kind of unheard of. That's what you do. You just progress from a band 5 to a band 6 to a band 7. You don't have to do that. Midwifery is so wide, isn't it? There's so much you can get involved in.
Yeah, absolutely. That's an incredible journey that you've been on. You've got such a breadth of knowledge and experience. And that kind of brings me on to thinking about the difference between leadership and management, because they are two different things, aren't they? But we sort of bound them together as one.
We do. And so anyone can be a leader. We're all in leadership roles as a midwife. Management does come probably with being a labour ward coordinator, matron level. So thinking about management, you tend to think about budget management, appraisals, disciplinaries, all those sorts of things. And managers can be leaders, but you don't have to be a leader can be a leader without being a manager, if that makes any sense at all. That's how I kind of see it in my head. So management isn't one of the pillars of a consultant midwife. Leadership is, and that's really important because we sit outside of management, which then affects the influence that you can have on change. And that's really, really important. And that's what allows you to go really deep level, rather than that kind of constant firefighting that you have to do as perhaps be somebody that's a bit more as operational manager. And for some people, that's absolutely what's in their skill set, what's in their strengths and what they want to achieve. And they're really, really good at that and kind of operational side and that management side. But for others, leadership for them means a little bit more kind of a wider picture, having that wider lens, a wider level of influence, and getting people on board with what you're doing rather than doing to people.
That's really interesting, because you're right. You're absolutely right. It's all about finding your skill set, isn't it, and what you're good at. And it might be that you're good at supporting a charity and good at fundraising. It might be good. You might be a really good leader in terms of speaking. You might be able to give presentations. You might be an organizer. You might be really good at admin. What about someone who wants to report something? So perhaps they've found something a bit concerning, or they're looking at a particular piece of equipment that they think might not be working properly and they want to report it. How can we encourage them to do that? Because I know there's a real sort of taboo at the moment about whistleblowing and the blame culture. How can we instill sort of confidence in midwives to actually speak up and report concerns?
I think for me, the first thing would be to definitely take the action. You don't want to ignore it. You don't want to, you've mentioned that broken equipment. You don't want to just leave it for somebody else to report it broken to get fixed, but then go on to find something else that works and use that instead. That doesn't help anybody. It's like putting an empty milk carton in the fridge, isn't it? And it's just the same thing. So you do want to take action, but there are so many different routes that you can take to raise concerns or to support the change that you want to in practice. And you can choose something that you feel comfortable with. And some examples might be to speak to somebody that you feel comfortable to speak to. You might have somebody who you have absolute faith and trust and confidence in that they could take your concern further. So that could be somebody senior to you. It could be a manager. It could be somebody else. It could be a colleague the same grade as you, but you feel that they might be better coming from them because they have a particular way about them. You think, do you know what? They're really good at doing this. Maybe they can take that for me. But then there's, and I'm just thinking about inside the trust here, but there's also, I know you used the word whistleblower in there, but that kind of confidence and ability to be able to speak up, and the freedom to speak up guardians, if you have something like that. If not, the freedom to speak up guardians within the trust offer that kind of confidential space where you can raise concerns. And the level of confidentiality, obviously, you'll have to discuss, because if you do want to have some level of change, you can't always maintain complete confidentiality. That's really, really important to understand. But you can work with them to say, well, how do I feel protected? How can I feel safe to be able to raise this? So you can do something about it while still protecting me or protecting myself. So freedom to speak up is another way. we've all got, as midwives, a professional midwifery advocate. And a lot of our professional midwifery advocates do report their themes and trends into Trust Board. So it might be that you go to them confidentially about something, and actually quite a lot of people have been saying the same thing about, I don't know, maybe about well-being or about how something we could do better within the trust. And they develop that as a theme, and then it gets taken as a theme to the Trust Board. We then have to kind of develop an action for that, so it's not come from a direct person. And some trusts even have, gosh, the name of it has escaped me, but it's an online tool where you can report, a reporting tool, and it could be a bullying, harassment, discrimination, and you can do it's an anonymous way of doing it. But again, if you're going to report some things anonymous that are quite serious, and you want change to happen, you do have to be a bit realistic of what change can happen if you're going to maintain complete anonymity. Don't know if I've said that word right there.
Yeah, no, that makes complete sense.
Yeah, so there are lots of channels, and you know, if you're part of a union, they can help with kind of speaking up and the voice as well. That there are lots of different ways. I just wouldn't, I wouldn't want anybody to feel that they shouldn't or they couldn't, because there are different routes that you can do that where, and it's just the way of thinking, well, I've got this issue, or I can see that this improvement needs to be made, or I've got a really good idea, but where do I take it next? There are lots of different ways that you could do that, and that's just some of them that I've explained there.
That's really helpful, and it works both ways, isn't it? It's about finding the right people, like you said, and building your allies, whether it's a problem that you want to try and solve and, you know, raise awareness of, or whether it's a completely new idea that you think, oh, I think this can really help and improve outcomes. It's about building the right sort of team behind you.
It is, and that team and those allies don't have to be where you work. You know, the job, I have been very open and honest to say that the job that I'm in at the moment can be quite lonely, and sometimes you do need to build those allies outside of the trust, and you know, they will absolutely support you and guide you and champion you, and there might be people in the same role as me, or the people who've implemented things that have worked really well. You know, I'm hoping that I've been an ally to some others that have gone, oh, do you know what, I really want to do what you've done. How did you manage to do that? What was your processes? And you know, that's the same way I achieved something might not work for them where they're working, but between us we could come up with, why don't you try this, or why don't you try that? So definitely building allies outside of where you work, and that might be outside of your NHS trust, it might be with other organisations, but it might just be in a different department. You know, hospitals have different ways that you can connect with other members of staff through, like staff networks, for example, and you know, you could use them to bounce some of your ideas off. Staff networks are great to be able to implement change as well. They have, or if your trust have got shared decision making councils, that's another one you could go to help support with implementing change. Yeah.
Okay, that is so helpful. That really is.
Yeah.
There's lots of different avenues to explore.
There is.
Different ways. And I've just thought of another thing that you've done to implement change, and that's when you brought in our mum and wellbeing wallets within the trust, which we've had a few years now, and I know you've seen great impact in them. Tell us about that. How have these helped, the wallets? Because I know you're still continuing with them at the moment.
Yeah, so we've had them for a couple of years, and the selling point for us and why we chose to go with the Mama wallets was because we could make them bespoke, and I'm not sure how many people are aware of that. But the Mama wallets we made them bespoke for our NHS trust. So we had our NHS trust logo on it, for example. We reviewed the information that was on there that was evidence-based, that's making a difference, but added some extras that were important for us to raise awareness about. So for example, not every trust is offering free vitamin D. We are. So we put on there on our bespoke Mama wallets, you know, don't forget to take your vitamin D, and you know, where you can get that from to serve as a prompt. We were able to put in our single point of contact number, so they can reach us, how you know, that pregnant person may want to raise a concern, so information about how to access our PAL service. So those sorts of things we were able to implement and change to make those wallets bespoke. We didn't want to change them too much because the content on there were already evidence-based that it was helping. So things like the what to do if you've got concerns about fecal movements and dietary advice in pregnancy, those sorts of things had already been proven that they were making a difference on those wallets. So we kept them, but just added a few little things that we thought was important to share.
Fletcher Solicitors are proud to support the Mama Academy by sponsoring this podcast series. At Fletcher Solicitors, we champion better maternity care for every birth, for every baby, for every family.
If you enjoyed listening to this episode, share it with a friend or colleague. Make sure you follow us so you don't miss out on our next episode. If you'd like to support our work by fundraising or volunteering, please email contact@mamaacademy.org.uk. For more information on pregnancy and maternity services, please visit our website at www.mamaacademy.org.uk. We're also on all of your favourite social media channels. See you next time!